review, because basically any guidance is based on the actual science of how this virus behaves. Next slide. Okay, so this is just a reminder, the screening criteria for COVID-19 in older adults, the usual fever and signs of lower respiratory infections. But I want to just bring you down to the caveat section where it says, older adults may not have fever, cough, chest discomfort, or sputum. They may present with delirium, elevated heart rate, all those things, falls, and just other really vague changes. So, and also that the definition of fever is different in older adults as well. And so having a temperature over 100 or a temperature consistently over 99 could also meet criteria for fever. Next slide. A little note about COVID transmission. The incubation period is between 2 to 14 days after exposure, which is why we have to be very careful when accepting these patients. And exposure occurs 48 hours before the onset of symptoms, and that people can transmit virus even when they are asymptomatic or if they are pre-symptomatic. Reminder that this is not just respiratory, also from contact from contaminated surfaces, and that everyone in the nursing facility is at high risk. So that's why anything that we try to do, we must be very conservative. Next slide. Wanted to just make you aware of some new research, some new clearance criteria from CDC and the Hawaii Department of Health that just came out 2 days ago. Basically, in order to be cleared from positive COVID, PCR, improvement of respiratory symptoms, and more than 72 hours after fever and myalgia is resolved without the use of fever-reducing medications, and more than 10 days since the symptoms first appeared, whichever is longer. Previously, the guidance said more than 7 days since symptoms appeared, but apparently based on recent research, viral cultures do not seem to be replicating virus after 8 days, and that viral load apparently is also not high enough to replicate quickly enough to be infectious after day 9. So based on these things, the guidance was changed to have more than 10 days since symptoms first appeared to be the symptom-based guidance for symptom-based clearance for COVID. That being said, many folks are not quite comfortable yet with not doing a test-based clearance. And so, we are still thinking that we may use test-based clearance of criteria for COVID, which is COVID test negative ×2 as an alternative for long-term care facilities. Because as I said before, long-term care facilities have to be extra cautious. Next slide. I'll say also some observations from COVID's clinical course that people have experienced. So this is lessons from Cantebury Rehab that was widely circulated among AMDA, and at the conference that we recently attended last month. So generally there are 4 types of clinical courses. One is the indolent fatal. So it starts out with a fever, kind of stabilizes, and then sudden worsening around day 5 and 7, which is basically the cytokine storm, and death despite maximal treatment, which happens in about 20% of cases. More of them, however, kind of close to 80%, you get the fever, stabilization, and then gradual improvement, but then we have to watch out for secondary pneumonia and requires close monitoring. Others, you might see that acute respiratory distress where you have sudden onset from symptom to death within 6 to 12 hours, and it's quite shocking. And then there is, those who are quote unquote asymptomatic, those basically without respiratory symptoms, but their symptoms are change in mental status and other vague signs like that we need to look out for. Next slide. Okay, so when is it reasonable to transfer to the skilled nursing facility? So, hopefully the patients have passed the window of the cytokine storm, and the hospitals, we'll leave it to the hospitals to recognize when it is safe. Patients, they're not going to be crashing on us at the SNF. Leave it to their clinical judgment. The majority will stabilize and improve gradually. So, but these should be monitored for the development of pneumonia, and the skilled nursing facility setting is a reasonable place for all of this to happen. We do this all the time, right? But because, and I have here the Trojan horse, right? Because this virus is just like the Trojan horse. They're hiding, nobody can see them. And you have to have all your firewalls up. And so next slide. So these are the firewalls that Dr. Sabine von Price, we talked about yesterday, right? Number 1, lockdown. Number 2, we need to have symptom screening for all facility staff. Number 3, stringent infection control, which includes universal use of surgical masks during patient care. Okay. Number 4 is basically lots of testing. That is testing all inpatients 48 to 72 hours prior to discharge to facility. And if the hospital has a defined COVID outbreak, all inpatients should receive 2 COVID-19 tests 24 hours apart. This was just something that was discussed at the HAH group. Okay. That was agreed upon earlier. And anyway, the testing also includes inpatients who are admitted for COVID symptoms, as well as those who were not admitted for COVID symptoms. And this includes testing patients for when considering transferring from COVID units and admission units into regular nursing home beds. I will discuss this more in detail in coming slides. And another firewall that we're going to talk about is having a COVID positive unit or a COVID positive room or just designated area, and that's for isolation in case any of your folks turn positive. You need a plan for that, right? And also firewall number 6 is to have a new admission unit, which is a quarantine unit. They don't have the disease, but we never know who's hiding in there and lurking as a Trojan horse, so we need to watch them closely. Next slide. So nursing facilities should be a priority, I would say, and so this plan actually requires a lot of PPE, and it also will consume more tests, as I'm beginning to allude to. But protecting our kupuna is worth it, and I believe our state is behind that, helping us supply more of the PPE and have more priority for testing. Next slide. Okay, so here it is. So patients are beginning to be discharged from the hospital, and so nursing homes are beginning to have these pre-admission COVID-19 screening prior to hospital to post-acute care transfer. And so, there are some key questions that we need to ask. I don't think we can just be accepting these patients on face value that, oh no, they're fine. We do need to ask key questions. Do they have symptoms suggestive of COVID-19? Were they considered a PUI? Was the patient tested in the hospital within 48 hours of discharge? Turns out, well, I guess HIH was saying 72 hours, but 48 to 72 hours of discharge, recent testing. Have the fevers resolved for the last 72 hours? Are respiratory symptoms improving? And how many days have passed since the onset of their symptoms? And the purpose of this is really to help inform nursing facilities where the patient should be admitted. Next slide. Okay, so I'm just going to walk through a proposed scenario, right? So say this is a non-COVID patient, so they were admitted for, I don't know, change in mental status and a UTI, and they were treated with antibiotics for urosepsis. And they're ready for discharge. We don't know if they had COVID or not because it was undetected. They didn't have symptoms, right, during the hospitalization. So everybody needs to have pre-admission screening tool to review the symptoms as well as a COVID test within 48 to 72 hours. And if they are COVID negative and have no symptoms, that's great. So they'll say, okay, let's see if we can admit them to the nursing home. But we want to put an extra barrier, extra valve of precaution here. So admit to a nursing admission unit to monitor for 7 to 14 days to pass any potential incubation period for undetected COVID. That involves the surgical mask, face gown, shield, face shield gown, and then active monitoring of O2 sat and symptoms, because symptoms might crop up at any point. If at any point they do crop up, of course, you're going to be retesting and continue to quarantine. Or actually, if they test positive, they probably should go to the COVID unit. But if they are not coming up with symptoms and they get better and they remain stable, then can consider transferring to the regular nursing home unit. If, however, we go down this thing, the COVID negative and they have no symptoms, if you have an answer of no to either one, ideally we would just keep them at the hospital until the COVID-19 test is negative ×2, which is kind of what we're doing right now, because we're very, very reluctant to get anybody with COVID positive into our facilities. But that scenario will only hold up as long as the hospital has beds. And so just thinking that we need an alternative plan. So the alternative plan would be that perhaps if facilities have a COVID unit, or admit to a COVID unit with full isolation precautions, and then we go to the COVID positive flow chart. Next slide. Okay, so if we have a PUI or a COVID positive patient, and those patients are no longer hospital level of care, or there's no room at the hospital, or something like that, the question is, what about their symptoms? Do they meet the symptom-based clearance criteria? If they are past the 10 days and supposedly the virus is not able to replicate and infect people, then technically they should be able to go to the nursing home. However, out of an abundance of precaution, we're going to say perhaps we should consider admission to a new admission unit for special monitoring for 14 days. And then, even extra precaution, COVID test negative ×2 and no symptoms for 72 hours before actually moving them into the regular nursing home unit or discharging home. If, on the other hand, this COVID positive patient going on the other side of the flow sheet does not meet all symptom-based clearance criteria, either by time-based or if they have symptoms, we're not going to take any chances, and we're going to admit them to the COVID unit with full isolation precautions, monitor, and COVID test before releasing them to any regular units, or keep them in the COVID unit until they are symptom-free or COVID test negative. Next slide. I know there's a lot of questions, but we'll go through those. I'm sure we're going to go through those afterwards. Okay, so this would be the facility COVID positive unit. This is designed, this would be for nursing home residents who develop symptoms or become PUI, or they test positive, right? This would be a separate unit or wing with a separate, ideally with a separate entrance or and exit to the outside, so they won't contaminate the rest of the building. And then all the staff there would be prepared to wear the N95 for aerosolizing procedures and surgical mask at other times, use face shields to protect their PPE, and long sleeve gowns all day, and gloves. And in this case, because we have everybody in the same unit and they're all positive anyway, we're not really protecting the patients from COVID, we're protecting the staff, so no need to actually change the gowns as frequently. And of course, have that system in place to reuse PPE. And then the residents should remain in this isolation unit until clearance criteria met. It is on this unit that patients should be monitored with vital signs and O2 sats. And Dr. Zavine says that, monitoring Q2 hours for hypoxia and Q4 hours for vital signs is important. Looking out for development of pneumonia or other complications, of course, providing rehab because they're probably very deconditioned as it is, and to be prepared for providing palliative care. This happens there. So have morphine and Ativan readily available and on hand. Next slide. Okay, and the new admissions unit would be considered, I guess we should look at it as a sort of a safety valve. It would serve as a safety valve preventing cases from getting into the main parts of the facility, where all staff wear surgical masks, face shields, and long sleeve isolation gowns. Note that these patients are not testing positive for COVID, so no need for the N95s at this point. But of course, should they develop any signs, symptoms, get tested, then they move over to the COVID unit. And then here we change PPEs between patients, because we're protecting both patients and staff. We do not want to spread anything that's hiding between patients. And of course, that system in place to reuse PPE, and the residents remain in quarantine 7 to 14 days, then transfer out. Next slide. And I just want a special word about hemodialysis patients. Many index patients are hemodialysis patients due to their frequency of transportation to the hemodialysis facilities. And so it is recommended that we keep HD patients in one room or one wing, and that they should be donning and doffing their gown and mask prior to getting their dialysis before leaving the facility. And then when they get back, thorough hand washing, shower, and everything. And that these patients do not get transferred back to the regular nursing facilities, nursing units, regular nursing home units. Next slide. And then just the note about protecting our regular nursing home units. We have to protect the majority of our nursing home residents who live here long-term. So we have to continue those physical distancing measures, restricting visitors, use of telemedicine, continue screening of staff. All staff have to continue wearing the surgical masks, not the cloth masks, continue face shields, gloves, but it could be debatable if you have a lack of long sleeve gowns, maybe you can go back to the short sleeve gowns. That's debatable as well. And of course, if you want to extend the life of your surgical masks, then you have a system for the reuse. Next slide. Okay, and I just want to emphasize that facility readiness is an important consideration, right? So if a facility is not yet ready, they should not be forced to take new admissions. Of course, they need to be working towards getting ready, but if they're not ready, it's not safe. So what does this facility readiness look like? We talked a little bit about it earlier, but yeah, universal masking, is that happening? Daily screening of healthcare workers. Are all staff trained and competent in those transmission-based precautions? Does the facility have enough PPE or isolation supplies? And I would say at least a 2-week supply, and then you can always call up to HHEM and they can drop you off a supply urgently if needed. Does the facility have private rooms available in case you need an immediate isolation? And does the facility have rooms or units designated for COVID positive patients, new admission units, and regular units? And also, does facility have a staffing plan in place to designate staff to each of those units without floating? Because if we have these great units and the staffing float, that's not really going to work. Next slide. And if we put all of these things in place, we should be ready for the battle. Okay, so if, John, can we, yeah. Well, the next slide is basically if there's a surge, but we're not going to talk about that yet because we're not, they're working on it. HIEMA is working on it, and hopefully we will have a plan in the next few weeks. But right now we're just talking about what are we going to do now, this week, next week. That's what we're talking about. Okay, great. So I'm going to now open this up to questions, and I'm going to, look at this big chat box. Okay. All right. Actually, not so bad. All right. No symptoms for as little as 7 days. Okay, to clear into general population. Isn't 14 days better? Yes, I feel better with 14 days, but I think the concern is, it might be clogging the system quite a bit if we do that. I don't know if Sabine, you want to mention your experience on that.
Well, I don't know what these symptoms, what that pertains to right now. If you send them out into the general population, have to make sure that the general population knows that they have been potentially positive, that they were positive, and that they have their own transmission-based precautions in place. I think 7 days is too short. I think 14 days is a minimum in my book. The debate about that is still going on. We're looking at different studies. The studies out of China showed that the virus shedding is really not happening after a certain amount of time. The studies out of my own nursing home, which has been featured in the New England Journal, Does also show viral clearance, but only after 9 days. So, and then I can tell you, we still have patients in that facility that test COVID positive. We don't know, is it truly replicable virus, or is it RNA trash, if you will? We just don't know, and the CDC is currently asking if you have patients like that, they stay positive forever, and I have some, that they get studied and see whether they actually have, by viral cultures, have actually viable virus. I have to tell you, I have lived through several COVID outbreaks, and it is a very dramatic and heartbreaking experience when 30% of your residents die, and it's not necessarily residents who are end-stage dementia and hospice. These may be residents on the rehab floor that die. These may be residents that are on dialysis but otherwise doing okay. So I tend to be extremely conservative, and I would not send anybody out with only 14 days after symptoms.
Yes, thank you. Patrick, I'm going to invite you to talk a little bit about your conversations with the stakeholders that you had this week.
Let's see, with regard to acute care transfers?
Yes.
Okay, so yes, thank you again, Ida, for reporting on that. We are looking at some potential changes here with respect to acute care transfers to nursing facilities and indeed long-term care. This includes adult residential care homes, assisted living, post-acute care facilities. Again, echoing comments and what we've seen elsewhere in the nation, we understand there's a very important need to protect our nursing facility populations. These patients tend to be elderly, geriatric populations with a lot of underlying conditions, and are particularly vulnerable to this virus's effects. So discussions have been ongoing about this, about the need to, again, protect and screen when possible. So what we're looking at doing is a test-based approach for patients prior to going into nursing facilities. This applies whether the patient's asymptomatic, whether there's no indication they've come into contact with the virus or had a potential exposure or not. Again, this is a single test-based approach within 72 hours prior to transfer. Right now, we are looking at doing this again. Our hospitals are on board with this, nursing facilities are on board with this. The goal, again, is to mitigate and reduce the risk, but not eliminate the risk of transmission of COVID-19 to our facilities. With that being said, I do want to strongly reiterate that a single negative test is not definitive of the absence of COVID-19 in a patient. Nursing facilities should still continue to strive and comply with these guidelines, ensure the facility readiness, and act accordingly when getting any new patient admission from a hospital or otherwise. Again, the single test result is not definitive here of the absence of COVID-19. Rather, what this approach does, again, is to help, again, weed out those that may potentially get into the facility. As we've seen elsewhere, there's quite a big, significant presentation of asymptomatic or pre-symptomatic patients with this virus. So this is in the efforts to weed out some of those patients, and again, to reduce the risk for our facilities. There are situations where 2 tests may be warranted. This is for those patients where they've previously been COVID positive, as Dr. Nguyen alluded to earlier in this presentation, or also whether they are currently PUI, a person under investigation for COVID-19. We're also looking at doing 2 tests, again, with negative results for healthcare facilities and hospitals which are currently experiencing active outbreak, as defined by the Hawaii Department of Health. This does not mean that there's simply COVID-19 in these facilities. Again, several hospitals are currently treating COVID-19 patients. Not to say that these are active outbreaks. Rather, what we're looking at is hospitals or facilities with active clusters and seeing inter-transmission of this virus within the centers. In those situations, we would also look at 2 tests, both showing negative, within 72 hours of a patient's admission to a long-term care unit. Again, for those facilities that do have inter-facility transfers, for example, both acute and geriatric or post-acute care, it's going to be up to these facilities to determine how they do it within the respective centers. But by and large, my understanding is these plans have already been underway. It's getting to surge planning, again, as Dr. Ida Nguyen mentioned, there are active plans on the side going with respect to surge plans. Right now, Hawaii has been very effective and successful in flattening the curve here in Hawaii. We have a very low prevalence or suggested prevalence based on testing so far in the state. This does not mean that we won't see resurgence in the future. It is very important that we continue to remain vigilant, that our facilities continue to prepare and act accordingly, and that we continue to mitigate the spread of this infection. As we begin to reopen our state, we will begin to see some potential hotspots or some potential clusters that do come up, and very well may end up in some of our post-acute care facilities. In the event this does occur, we are looking at some potential surge plans with some potential SNFs or facilities taking on some of these COVID positive patients or former COVID patients, but discussions are still ongoing.
Thank you. All right, so we have a question from Maria. Are cloth masks still okay to use currently? I'll let Caitlin respond to that.
We really want people to be using medical grade face masks in all patient care activities. Really, if you're having trouble with PPE, reach out, maybe Patrick, I'll volunteer you, but or whatever your normal channels are to get access to that stockpile. We've seen a handful of facilities that, I think really because they had implemented universal masking of medical grade face masks, they avoided tragedy, I think, in some close calls. So I do think that this is really important. And we're saying maybe cloth face masks might be okay for people who aren't directly involved in patient care duties, but that's with a huge caveat is that we are seeing the potential for transmission among healthcare worker to healthcare worker before and after shifts and in the break rooms. So we don't want people to let their guard down just because they're not directly in patient care. So we know people have to take their mask off to eat lunch, things like this, but make sure that's when the social distancing is going to be really, really important for your staff.
Just a reminder, please mute if you're not speaking. Okay, next question. What about testing every 72 hours for 14 days so the quarantine is over to make sure they're not converting to from negative to positive, even after 2 negative test results prior to going to long-term care? What do you do? Well, what do you think, Sabine? Is that overkill? Unmute.
I think that's a little bit overkill. I don't know how it is in Hawaii, but test materials are still a rare commodity here, and I don't know that even after 72 hours, if you still think you're in the incubation period, that it gives you any extra protection. I don't think it would change your practice that much. I think you probably want to keep people in a quarantine situation after hospitalization for 7 to 14 days. Again, the jury is still out. I mean, different people are employing different strategies here. But if you think that a patient who tested negative before they came into, and by the way, Patrick, you guys are doing great. I think these are strategies that you described that we've been employing or getting to here in Seattle, finally as of 2 to 3 weeks ago. And I totally agree with them. So if you have a COVID negative patient, they test negative before transfer, now they're in the observation unit, you theoretically don't know whether they're still in the incubation period, and testing them every 3 days would not give you any security beyond that. So I think it's really the time. And then after the 14 days, if you want to test, that is definitely will give you a very nice sense of security. May I make a few comments on your presentation, which I think was fantastic. I don't think I've seen such a good presentation going through what you can do actually ever, and that includes my own. I did want to make a few comments though. So you mentioned that the COVID unit would be for positive COVID patient and PUIs, and I want to make a very strong case for that not to be the case. I do not think you should, a COVID unit is only for COVID patients, because the PUIs, you don't know whether they're positive or not, so you could turn them positive. So I want to be very clear, COVID unit for COVID confirmed patients only. The PUIs could go into the step-down unit, and you can and you do the donning and doffing and the transmission-based precautions there. The other comment I wanted to make is N95s. And I think I sent you the Joint Commission guidance on masks. And maybe, Caitlin, you have another take on that, but the Joint Commission and the CDCs both say that N95 masks are not necessary, even with a known COVID patient, unless they're aerosol generating procedures, which I just talked to an infectious disease specialist actually within an hour ago, so things change fast for me too. And they said that obviously nebulizers is something that we don't want to be doing regularly in nursing homes anymore, but CPAP machine was on the CDC list, but he made the argument that CPAP machines for the home are too weak to cause aerosolation. So even then, he did not recommend N95. And I have been always quite nervous about not using N95, and we all have read the studies where they pick virus out of the air, and is this really not aerosolizing? And he said basically the R value, which is how many people get infected by one case, is being fairly solidly around 2.5, so 2.5. Versus there are viruses out there that actually go by aerosolization, for example, measles, where the R value is much higher, so 8 to 9. So I'm now finally convinced that it's probably not an aerosolized value, which calms me down greatly. So those were, so in other words, N95 not necessary. If you just have surgical masks, you will be good. Don't use cloth masks. I totally agree. Use them on the outside when you go to the beach or whatever. I don't know whether you're even allowed to do that. So.
Okay.
Oh, by the way, there's also a PPE calculator by the CDC. Are you aware of that?
Yes.
Okay, good. So you could maybe have a link on your website if you need to calculate the PPE that you will need.
Okay, great. Okay. Okay, so yeah, testing at day 14, we talked a little bit about that. I think that that's the safest thing to do if we're going to be transferring people out of that observation unit or out of the COVID unit. Do we need to isolate differently if patient came from acute hospital versus a lateral transfer from another SNF?
I'll take my stab at that. I don't think so, as long as there's no reason to believe that they're a COVID patient if they're completely asymptomatic and they're just going into your new admissions waiting area. I think that all of your new admissions could go there and wait out that 14-day incubation period. If there's no other reason to believe that they were exposed or otherwise a COVID positive or PUI, then I think that would be appropriate. Do you guys agree?
Yeah. Okay. So, wow, is that the end of the questions? I'm sure people have more questions or something they want to discuss. Any questions? Okay, so I'm gonna throw something out there. You know, from basically everything I've seen, I think, you know, basically what's recommended is that facilities should have these 3 pots, you know, the COVID positive unit pot, the observation place, as well as having the regular unit. And I don't know, it's not always feasible, especially if it's a very small facility. Like, how do you, the thing only has 2 units or 3 units, you know? You don't have that many, and where you're going to put all your regular patients. It's very hard to move people around. What do you guys do? Do all of your facilities have these 3 different areas designated, separated out, Sabine?
So, you know, those COVID units can be very small too, right? So the way we have generated COVID units, we are taking construction lining. And these are just construction fences. They're out of plastic and have zippers. And you should now be looking at, it doesn't have to be a whole wing. You should now be looking ideally at a situation where you have a separate entrance. Put that zippered fence up, if you will, and bingo, you got your COVID unit. And then the interval unit could be just your post-acute care unit, really, could be a part of that. Or you have a one unit, and part of that is the COVID positive unit. But so I think that you don't need to do necessarily a lot, but you have to be prepared and look at it. If you haven't done it yet, look at it now. So right now, I have a patient in one of my facilities who one patient COVID unit, and that's exactly what it is. And it's right by the stairwell, and one CNA takes care of that patient and actually gives the meds as well. So that patient isn't that sick. I just want to say also about the regular nursing home, and you've probably covered this, you have to have now a high index of suspicion, and probably should be doing a line listing for anybody who has any kind of potentially COVID-related symptoms. I want to let you know that that the patients that I have been seeing and that were COVID positive, the temperature of over 100 is the exception rather than the rule, unless they go longer into their disease trajectory and have cytokine storm and so on. What we see, I have had the opportunity now to follow many patients from being COVID negative to being COVID positive, or being COVID positive to actually developing symptoms. This is a process that can take weeks. So what I suggest is that you do Q4-hour monitoring. If there's any evidence that there is potentially hypoxia developing, you should definitely ramp up to Q2 hours for the exact same reasons that you said. We have developed our rule of thumb is if hospitalization is within the patient goals, and 91% or less oxygen saturation, or a delta of 3 going into the lower 90s should prompt hospitalization. And then any other unstable vital signs anyways. A high fever should probably also prompt hospitalization if the patient, that's part of the patient's goal, because a high fever will show you a high viral load.
Okay, thank you. What are your recommendations for patients who return from an ER evaluation?
Good question. I let the ID people take charge of that one. I have an opinion, but maybe I'm not the best qualified.
Does DOH have any recommendations on that?
Well, I guess we can discuss it a little bit. I think we should, anyone who's exiting and entering the facility does pose a risk for being exposed wherever they were and then introducing it into the facility. So maybe we can think about it almost a similar way as we're thinking about the hemodialysis patients.
Yeah, okay.
Yeah, or you put them in the observation unit. I think that might be a very good idea, because there was probably a reason why they went into the ER. I had a case that triggered an outbreak. They went into the ED. You don't even want to know, but they went into the ED with a fever and respiratory symptoms. They were tested, but at the time, testing took 5 days to return back. They came back. The nurse understood that testing was negative. The patient then turned positive. The attending physician left a voicemail on the patient's cell phone. And we've had now 10 deaths, I think. And that was that patient. Really tragic. So yes, ED, I would say my index of suspicion would be just very high, because there's usually a reason why they go to the ED, and then of course the exposure there.
Thank you. All right, so just Alice just wants to confirm, right? No N95 needed for patients in SNF in isolation, just surgical mask unless there's an aerosolizing procedure, right? Yes. Okay, in a facility if a facility cannot sustain a 14-day quarantine, what would be the minimum days you would recommend isolating a new admission? It's not isolation, it's quarantine.
It's quarantine, yes. Well, I've seen it from 3 to 7 days. Yeah, of course, that would presume that they are monitored closely, don't have any symptoms, have been COVID negative prior to transfer. I personally think 7 days is probably the minimum, but I have seen facilities do it with as little as 3 days. And you could say 3 days and then introduce them into a single room. That might be another strategy in a regular unit, and have, of course, all personnel wear face masks and face shields and the hand washing and the gloves anyway. So.
Okay, right.
Yeah, I think, there's just no way around that 14-day incubation period. No amount of testing you do or monitoring you do, you just have to wait out those 14 days, and that's just how it is. But I know in the reality, it can be hard to sustain this 14-day quarantine. So I think as much as possible, the plan should be 14 days. And then as that becomes impossible, you can maybe reconsider and minimizing it. But that 14-day maximum incubation period is just, it just is.
Okay, great. All right, so Heather Haynes is going to parse this out a little bit, and yet what about having a separate PUI unit? So is it COVID, an OBS unit, PUI unit as well, or what do you think, Sabine?
I think the PUIs should probably stay where they are, and you should probably remove the roommate, but don't put them together with somebody else, because otherwise it's really tough moving patients around a lot. I think that's why you should now look at the COVID unit, so that you only have COVID people there. Because what we have also done in this case that I just talked about, we initially removed all the negatives out of the unit that we designated as COVID unit, and we triggered an outbreak in another unit. So, so I think this whole testing is, hey, if somebody's positive, do everything you need to do. If somebody's negative, beware, because they could be turning positive on you. So don't move them around a lot. Ideally, that would be moving if you have the capacity to move them into a single room, that would be good, and then just do your transmission-based precautions. If you can't, you could maybe move the roommate away, but don't move the roommate in with somebody else, because the roommate is likely affected if this is going to turn out positive. So tough it out.
Yes, wow. Okay.
Yeah. Difficult.
Yes. Okay. So what is a good strategy for avoiding risk transmission from contracted rehab therapists visiting multiple SNF facilities? I bet that's based on experience.
And does anybody want to take a stab at it? But I've had experience and it's not been good.
I think it's a great point. Some of these staff, I think some of the imaging techs, just go among all of our facilities, and it's really high risk. I think we've all accepted that the most likely introduction into a facility is probably going to be a healthcare worker, maybe an asymptomatic healthcare worker. So I think just making sure they adhere to your facility's policies and procedures, making you're including them in your screening of anyone who's entering your facility, making sure they're wearing their PPE, their universal masking, just like your other staff are doing.
And I think that's particularly well, I think, executed with lab technicians and x-ray technicians. They should be bringing their own PPE so that they don't use your PPE, but it should be fresh and not reused. It should be donned right in the facility after they have been symptom checked. And with therapists, I think there could be an argument made that they shouldn't be floating in between facilities. I tell you, I don't float as a physician, and I mean the same thing is true for physicians, frankly, as well. And the big Achilles tendon for us was the floating staff, not only within the building, but from building to building. I think Hawaii may be a little different there, but in Seattle or in Washington is part of the culture that our staff work very, very hard and they go to different facilities. So in the beginning of the outbreaks, and so this facility that was written up in the New England Journal, the second facility and my facility, they had a mutual staff with Life Care Center of Kirkland. And that staff got sick. Didn't tell us, of course, but had worked with us when we didn't even know that there was such a thing as COVID in facilities. So that was the last week in February, and they got sick. We immediately said, you can't come, but we couldn't locate her. She ended up being hospitalized and positive, and that's how our outbreak got triggered. And it got accelerated by a physical therapist who came in and was sick during the day. So you make sure your policies and procedures also cover that if anybody feels sick during the day while they're working, that they immediately stop working, notify the supervisor, and leave. There has been an outbreak in Pasco in Eastern Washington that centered around a therapy group. And one of our facilities now has a COVID unit with 13 patients in it, all around that. So it's just tricky, very tricky. So what we have done, so initially I said, you need to just register with us where else you work so we can notify the other facility. Now that was in the beginning of March. And now I'm nope, can't, and we are really like, you cannot work anywhere else. You have to decide which facility you work and we will give you more work. Which we're always short on staff. So, I mean, there's always opportunities. So, but that's how I would negotiate that. Yeah, make sure your staff isn't floating between facilities because that's a kiss of death.
That's exactly the same situation here in Hawaii. And I was going to ask that question and you just raised that, So, yeah, so how do you make people not work their 3 jobs,
Mm-hmm.
But it sounds like you just promised them that you're going to give them more work.
Yes, that's how you have to do it.
And I would imagine if there's a rehab company that you're contracting with, if they have, X number of employees, they can divvy them up and just say, okay, 2 of you go here, 2 of you assigned there, and 2 of you assigned in the other facility, and that's it, you don't change. I suppose that's something we can negotiate with our therapy partners.
Yes. But they don't want that to happen either, right? I mean,
yeah, no, good thought, because otherwise, we can't not have our patients not get therapy.
No, you would divvy it up.
Yeah.
But yeah, those staff that float, that has cost, I mean, as of right now, like this one case is 20 deaths right there.
Yeah, and the same with agencies, right? The agency.
Oh boy, yes. Yeah, but if you have staff that doesn't float, maybe you don't need the agency because you have extra staff, right? Maybe, or staff that wants to work more, so maybe you don't need the agency,
Okay, great. Let's see. Here it says, if you have floating staff from building to building, do you have them shower and change before working? Do you offer them
really?
shower?
I don't think that's going to help.
No.
It's not bad, but I don't think when push comes to shove, that's not going to help.
Okay.
What might help is the face mask and the face shield and all the other infection control things, but just don't do it. And I have to say something that is maybe very unpopular. I myself, having seen too many outbreaks, if you're COVID naive, don't take a COVID positive recovery patient from a hospital. That's all I'm saying. If you have a really well-functioning COVID unit, you might consider it, but I would not invite trouble into my building. But that's just my personal opinion.
Okay. Thank you. All right.
I think I will only supplement that and say I understand everyone's going to try their best to keep COVID out, but it could pop up at any time despite all of your best efforts. So even if your plan, even if we don't agree with it, even if you're saying, no, we will never accept a COVID patient, even if DOH doesn't agree with that, it could still enter at any time. So it's not a reason to not prepare.
Thank you.
And I want to just echo Mike Wasserman, who said it's not about whether you get COVID in your facility, doesn't say anything about your quality, but what you do with it once you get it. That's more what it's about.
Great. Yes. Okay. So while people want to continue maybe typing any questions or things like that, I'm just going to have people take note that if you haven't typed your name out into the attendance, please do so. And there's a link for the evaluations. And if people on the phone want to unmute yourself and just give us your name, you could do that while we're waiting.
Hi, Carrie Pitcher, Kula Hospital.
Okay. Okay. Anybody else? Okay. And thank you, Patrick, for joining us for this hour. Appreciate it. Okay. And all right, great. All right, well, thank you, everybody, for joining us and engaging in this discussion. If you have any more questions or input, please feel free to contact us so that we can tweak this thing a little bit more and, improve the guidance. And of course, this is just a fluid situation. And I know everybody's just doing the best they can, and we really appreciate it. Thank you. Thank you so much.
Thank you.